Cognitive behavioral therapy, or CBT, is a short-term, goal-oriented psychological treatment. It focuses on thoughts, feelings, and behaviors, aiming to manage problems by changing thought patterns and modifying core dysfunctional beliefs. CBT case conceptualization includes three main components: automatic thoughts, core beliefs, and behaviors that maintain anxiety or depression. These elements interact and reinforce the cycle of distress. Key CBT skills used in this case include psychoeducation, cognitive restructuring, worry management, behavioral activation, problem-solving skills, exposure therapy, assertiveness training, and relaxation and emotion regulation. We examine a case study of Amina's experience with anxiety and depression. Her anxiety symptoms include persistent worry and difficulty concentrating, while depressive symptoms involve diminished interest and feelings of hopelessness, worsened by job demands and stress. Amina's personal history reveals a high achievement and perfectionism background, equating self-worth with performance. Her medical history is unremarkable, but there is a family history of anxiety. The CBT case conceptualization for Amina identifies core beliefs like, "I am not good enough." Intermediate beliefs include, "I must perform perfectly to be valued." Automatic thoughts are, "I'm going to mess this up." The cognitive behavioral cycle shows how a situation, such as a new work assignment, leads to thoughts like, "I won't be able to handle this." This triggers emotions like anxiety, resulting in behaviors such as procrastination and an outcome of increased anxiety. CBT-aligned treatment goals focus on reducing anxiety and improving cognitive flexibility, decreasing depression through behavioral activation, challenging maladaptive core beliefs, and improving coping skills for stress and emotional regulation. Key CBT interventions include psychoeducation, worry management techniques, structured problem-solving skills, and assertiveness training to improve communication and boundary setting. Further CBT interventions are cognitive restructuring to reframe negative thought patterns, behavioral activation for mood improvement, gradual exposure therapy to reduce anxiety, and relaxation and emotion regulation practices. Psychoeducation helped the client understand the CBT model and normalize symptoms. This increased insight and reduced self-blame, as the client saw how thoughts, emotions, and behaviors interact to maintain the cycle. Worry management involved introducing a designated, quote, worry time and cognitive diffusion, labeling worries as, quote, mental noise. This decreased rumination and improved the client's concentration. Structured problem-solving skills addressed feelings of overwhelm by breaking tasks into smaller steps. This reduced anxiety-driven rumination and increased the client's confidence in managing stressors independently. Assertiveness training used role play to practice clear communication. The client learned to use I statements to express needs, leading to reduced resentment and decreased anxiety in interpersonal situations. Cognitive restructuring used a thought record to challenge the belief, "If I make a mistake, I'll be seen as incompetent." By balancing the evidence, anxiety decreased, and the client felt more willing to engage with tasks. Behavioral activation countered depressive avoidance by scheduling enjoyable and rewarding activities. The client reported improved energy and mood, adopting the philosophy, "We'll act first and let motivation catch up." Exposure therapy involved creating a fear hierarchy for work-related anxiety. Gradual exposure to avoided tasks, while refraining from safety behaviors like overchecking, increased the client's confidence in tolerating uncertainty. Relaxation and emotion regulation skills, such as diaphragmatic breathing and progressive muscle relaxation, reduced somatic anxiety. This led to fewer panic symptoms and improved sleep quality. Key takeaways show that anxiety and depression are maintained by maladaptive cycles. CBT targets thoughts, behaviors, and coping skills simultaneously. Small, consistent skill use and real-world practice lead to meaningful clinical change.